We can.
Awesome. So so there's a lot. So thanks for being flexible. Always wonderful to speak to you guys here at RETAC and so in Colorado. Wish I was there with you, but unfortunately cannot be. But there's a lot going on right now, and we will get to some of it around the surprise billing on the federal level as the committee meets, and we convene next week for our final meeting where you'll hear a lot about the recommendations that the committee is going to put forth on how states and federal officials should deal with the balance billing around ground ambulance. If they do something in Congress or at the local level, what some of the recommendations from this committee that has met from all perspectives. And so we have been meeting rigorously, and it is really ramped up in the meeting, unfortunately. So needless to say, some of us have been working 16-hour days to try to get this done. And we had to call another meeting of the committee or the subcommittee for this afternoon, was around the same time as my presentation was going to be. So I thank Scott Moore for allowing for that. As a general point, as I get through, I'm going to talk through a lot of things around cost data and what to expect as we're beginning to see some things there. I'm going to let you know some information there. I'm going to talk a little bit about the surprise billing. I know you guys are working on some initiatives there in Colorado. I know you've been working on them. You've got some stuff related to that, things that you need to pay attention to. There's going to be some things that are notably not going to be listed in the slide. There's some things I can talk about. There's others I may not be able to opine on yet, and some I can. And so we'll open that up to at least allow you some time to have some Q&A through that process and some lessons learned through that. And then there's also some other things that I'm going to want to make available to you. I am going to suggest, if you can see this, that you get your phones ready, because I do have some information that's going to be available to you that you can actually scan the QR code and you can download the information as well. And then you'll be able to download this presentation in order to, if there's some data on there as well at the very end, I do have the ability for you to do that. And then, of course, I'll get this information over to Kim too. So before I get started, any questions before I get going, or I'm going to maneuver through this as quickly as I can to make sure I maximize your time? Good. Okay. We're good. All right. So let's get through some of the stuff. As most know, of course, I have to do a plug for Solutions Group. So if you want to know about Solutions Group, we predominantly do a lot of technology. But go to solutionsgroup.com as well. And we will we'll be more than happy to assist you in anything that you can. We are growing. We're a growing team. Here's just a little bit of our happy faces through the process. And here's a little bit about, so far, the offerings that we do provide. Stay tuned. There are many new things. There's going to be some announcements happening right after Thanksgiving and into December that I think will be interesting to many of you that might be in the room as well, about some other stuff that we'll be offering too. So really excited about it, excited about being in the emergency services space and other spaces outside of emergency services as well. So let's go through and first hit what everybody's talking about, what I probably get the most calls on right now, and that is relative to the No Surprises Act, what's going on. I'm going to talk you through some of the cost data collection pieces, what to expect there, as well as some things that are going on with the Veterans Administration. Some know about this issue, some don't. So I want to give you a really quick and dirty regarding that, as well as some work that's being done by a lot of the industry, especially on the national level. That could be something that you get involved in if it's going to be impactful to you at all. And then what some are talking about the next 18 months. We finally have a speaker in the House. And so some of the dysfunction that has played out with no speaker, they can get back to work. And then we shall see how that plays out with policy and other matters within the next 18 months. And is there any impact of that happening, and what does that look like for EMS as well? I don't know what keeps happening here, but my apologies. Let's see if we can get this right. So I'm going to just do really quick, and most of us know what we're talking about is the No Surprises Act. Is something that got put in in 2021 under the Consolidated Appropriations Act. Remember, and I think this historical context is really important for the ground ambulance industry to really understand as we're working through this, is the No Surprises Act, most people thought was dead. There had been a lot of discussions happening around it since 2016 and 2017 around what the constructs of banning balance billing could be, but there was a fight and a war between payers, insurers, and providers around what that would look like. And so it was just pretty much stalling out. There was a lot of conversation. There was a lot of stuff going on in the media around this. And this was a long process that was happening. When the Consolidated Appropriations Act was passed in 2021, in late November, this was passed at the very end of December 21st, as you can see here, as Donald Trump was moving out of the presidency and was moving into a new president, the Biden administration. They passed one of the last packages of the Trump administration, and at the last minute, the No Surprises Act received legs. And this was an area with air ambulance and ground ambulance. Ground ambulance thought they were exempt, and at the last minute, we heard from the chair of Ed and Labor that they wanted to include ground ambulance services into the current construct of the No Surprises Act. And the ground ambulance industry just went on a extensive lobbying effort to make sure that did not happen. And what we wound up with was what I'll talk about is this advisory committee that currently has met to understand the dynamics of the EMS industry, because we were so locally regulated, which was unlike the air ambulance industry. And so air ambulance was never going to be exempt. There's a lot of stuff that went through that process, and then this passed and it was inserted in. But it was a surprise to a lot of people. It was a major bill that was put in here. So understanding historical context on how this worked, this same issue could happen to ground ambulance. So if you have not passed something at the state level, it doesn't mean that Congress, in their wisdom, couldn't do something and just say, insert ground ambulance in, and there's really no recommendations, and they take whatever work that they've heard about or done and insert ground ambulance in, even without the final report and recommendations from the committee that has been meeting. That is the same thing that happened to the air ambulance industry. Okay, air ambulance was inserted into the No Surprises Act, and the committee report didn't come out for almost a year and a half later. Okay, so just remember that context is important, and I think it's important to note that as we work through this. Remember the No Surprises Act, and this is another thing that I keep hearing from ground ambulance community as well, is it does not cover the Social Security Act. Okay, that means Medicare, Medicaid, Indian Health Services, Veterans Affairs, and others. No provisions within the No Surprises Act impact those sections as well. It amends 4 of the pieces of code. So think Public Health Services Act, think ERISA, that's where most of your issues are. These are the self-funded plans. The Internal Revenue Code, most are like, why is the IRS involved? Think church plans, church health plans, and then the Federal Health Benefits Program. It has the oversight of the tri-agencies. And so there are 3 secretaries involved: the Secretaries of Labor, Treasury, and HHS. HHS is who we usually deal with a lot because that oversights the Medicare and Medicaid programs as well. But remember, this is a tri-agency thing with the Secretary of HHS being the lead secretary. So sometimes people wonder, why is it taking so long to promulgate a rule? Why does it take them so long to do something else? Because they have to have the approval of all agencies before they can issue anything. So it really belabors the point through the process. The reason why you know this is a large bill to implement is because follow the money. About $500 million was appropriated to the implementation of this act, and it will expend itself at the end of next year. We do expect that is probably, they're going to allow that to fund some more money into it because they are far from implementing this bill. Needless to say, I'm not going to tell you all this. Pretty much this takes everybody out of the middle. It's basically removing the patients out of the middle, but there was 4 key provisions through this. It's protecting the patient, It's allowing for a negotiated reimbursement, and it only holds the patient liable for their in-network rate. What it would have been if they use an out-of-network provider, it only is going to make them liable for what their patient responsibility would have been had they used an in-network provider as well. The one thing too is what's in dispute right now, this independent dispute resolution process. This is where all those lawsuits are happening, and I'll explain that as well. Allows for that. The one piece that you should note here is at the very bottom of the screen. And this is requiring providers and health plans to assist patients in accessing healthcare cost information. This is what we call the transparency provision. You're beginning to see more and more of that percolate. You saw now how insurers have to provide what type of contracts that they have. You already see a lot of transparency happening in hospitals. How can patients get to their information in a more expeditious manner, that they don't have to look for your rates in ordinance? They don't have to go to a local ordinance, try to find them. There's no state repository for that. So think you're going to see a lot more around transparency. We're not talking about that a lot as an industry, but transparency, I can't say that more. Some of us have been saying it for several years now. If our industry could get out ahead of transparency, some of the issues that we're facing right now probably would go away. The other piece is accountability. And so what we need to understand is there's a lot of reports that Congress has asked for to see, is this working? Is the bill working as we intended it to happen? And so they required a report in 2023, really trying to understand the integration and cost and access issues. Is there enough information since we've implemented it? Have we seen increased cost in certain areas? Have we seen access issues in certain areas? They also, by 2025, want to report on networks, premiums on the insurance side, out-of-pocket costs. Have we seen some issues with that? Notice, this is January 2025, the report's supposed to come out. So they won't even know enough more information for another year and a half to really understand this. We're hearing anecdotal information, but this will be the GAO actually doing a comprehensive, and they're already starting to work on that. The next one is network adequacy. This gets a lot to what we're talking about access, but adequate networks. Are we losing certain networks through that? And there has been a preliminary report done on that. And then this independent dispute resolution process, we're expecting to come out anytime now, but they are required to have this report out regarding this issue with these IDRs, and there's been numerous lawsuits regarding this as well. Here's your first report that I want you to understand and look at. Oftentimes, and you can scan this too as well if you'd like to know this, if you're one of those policy wonks like I am. This gives you the first report that we talked about, really trying to understand the different trends and analysis around access and things, just preliminary information on cost. As you can probably believe, there's not a lot of information because it was only a year into implementation, and it had a very stalled implementation at that. And so basically, if you want to report from the GAO and others that actually give you kind of nonpartisan information, that you're not looking at some think tanks that might be on the left side or the right side of things politically, this gives you some more information. So in this report, it's going to give you information related to what states actually had surprise billing protections before the NSA prior to 2021. So it's going to tell you very quickly how many have comprehensive and what they look like, if some states have partial, and if some states have no protections. So you can see the red is no protections. So there's a lot of states with no protections. And there are probably an equal amount of states with some comprehensive protections here. This is the good data for you to understand where things were prior to 2021. What you should pay attention to is basically they didn't really have enough information to understand the full impact. They need more data. They do have another report that is required first part of next year. So we should get us some more comprehensive information around that piece of it. The one thing that I do think you should note that I pulled directly out of the report that I thought was interesting for especially the ambulance community to understand is, while the primary intended effect of the NSA was to reduce the number of surprise bills, they saw that there were several potential healthcare market impacts that were possibly going to occur. That means they are thinking there is going to be access issues for patients in certain regions of the nation, and not in all regions, but they really believe there is going to be some inadvertent potential healthcare impacts to consumers due to some of the effects of the No Surprises Act. And I think you're starting to see anecdotal information begin to pop up. Now, we're seeing it in the ground ambulance space, and I'm not sure we can attribute it directly to anything with the No Surprises Act. That might be with workforce shortages, but it's interesting to watch what's happening with some of the other healthcare sectors to determine if some of that actually could come our way, and some of those things that we might need to be addressing in the No Surprises Act as well. The next thing is the next report that you want to pay attention to that just came out as well, if you're not aware of this, is the one that just came out at the end of last year, that they were required to look at the network adequacy provisions, okay, and what they determined. And this is very important. This is interesting for the ground ambulance industry and for many people that have been advocating for certain things. So I'll give you a second here so you can download this as well if you have not already seen it. This would be really good information if you're doing something in one space. I want you to know what this report showed. Of course, data was not comprehensive enough, but notice bullet number 2. There is provider shortages, and they were noted in the mental and behavioral health. Well, no crap, Sherlock. Of course, we saw this. EMS has been seeing that there has been this issue in the mental and behavioral space for years. And unfortunately, we have been tagged on to provide this. Many are working in MIH, CP programs, others like that, to try to work together with concerted group. But this is really important to note, because really, I believe the EMS industry can continue to be the gap that helps with some of these programs that they're having. Provider contracting challenges. GAO came out with this report that they're showing the provider contracting challenges. Well, of course, we knew that. We knew there were issues with contracts already. And it could be on the issuer side as well as some of this report. Remember, it's more than just air ambulance and ground ambulance is not even included in this report because we are excluded out of the No Surprises Act. But other healthcare providers are moving out of contracts, or there was contracts. So there's a lot of gaming of the system happening with the insurers, as well as can't let some of the providers were gaming as well. Not all, but there were some providers too gaming the system too. But it's really, really important to note in some of these areas. The other thing was geographical challenges, which we know is in the ground ambulance industry. We know that specifically in the state of Colorado is one of them, where you have large urban areas, large rural areas, frontier areas, physical barriers that could cause adequate networks, which any provision within the No Surprise Act could inadvertently impact that as well. And so how can the local community assist with that? And then what does the federal government need to do in case the local community has not addressed that? So this is a really important point. I'd actually read it. It's actually some information there that's relevant to what you're going through right now. So what are the lessons learned? What have we actually learned from the air ambulance industry that we as a ground ambulance industry need to address, whether it's on the state level or not? The one thing that we learned from the ambulance industry, I alluded to earlier, is Congress doesn't need an advisory committee to tell them what to do in order to act. The first thing that you should know. So if you're waiting on the federal government to solve a state problem, they have to solve this problem and either give the state the direct authority, which has been done in the No Surprises Act. And so states should be really looking at what they're doing on that level and what's going to happen there. So that's probably the first thing that we should learn, because technically Congress doesn't need an advisory committee from the ground ambulance industry to tell them. They did the same thing with air ambulance. There was a committee set up on how to address it, and they enacted their provisions as they thought, with effective lobbying by those in the air ambulance industry. And what you have is what you see in the No Surprises Act. Okay, that's the first lesson we should have learned. The second lesson that we should learn is, if we get inserted in and we do not address this independent dispute resolution or this appeals process, that could be detrimental to the industry as well. We know that the majority of the industry is very small. They do not have the resources to dispute, very similar to the physician community. Air ambulance, predominantly 75% of the claims utilization in air ambulance is done by 4 main providers. But the rest of the air ambulance provider is small. They might have 1 helicopter, 2 rotary wing, a few fixed wing, and so much smaller, larger dollar amounts in bills, but smaller amount of administrative help to assist them. And so it's been some challenge for some of the air ambulance, especially smaller ones, to work through this IDR process that is continuing to evolve. Numerous lawsuits has created aging that has gone from what used to be 70 to 80 days in day sales outstanding is upwards of over 200 days for a lot of providers. Max providers that are reporting on this that work for hospital-based air ambulance services are very small, small air ambulance services. Some are reporting up to 300 days in AR for stuff that's commercial related. And so that is something that the ground ambulance industry is also looking at. The next thing is there is not any definition or concerted area around an amount that the insurers are required to pay, okay, if the state law does not address it. And because in the air ambulance industry, the Airline Deregulation Act prohibits states from addressing rates and routes, the federal law is going to apply. And unfortunately, the current NSA structure does not establish a rate structure for your initial payment. Technically, the insurers can pay whatever they want, or they can deny it, or they can stall it asking for more information. And that has been a lessons learned for the ground ambulance industry that probably needs to be addressed or modified within the current construct of the No Surprises Act. The one good thing for the ground ambulance industry is the counterparts in the air. And if you're in air in this room, then it probably isn't so good for you, but you are what I would call the beta test children. So the air ambulance industry and the other healthcare providers that have been inserted are baiting all these new laws that have been implemented through all these regulations. And so all of these regulations and the secretaries that have been putting out regulation that contradicts to the law, you're seeing a lot of lawsuits. And so we've seen 4 lawsuits that most refer to as the TMA or the Texas Medical Association that has been at the front line of these lawsuits. A lot of them are calling them the TMA lawsuits. And they've addressed everything from this qualifying payment amount and how that has been used in the dispute process to there was actually an air lawsuit that looked at certain elements related to like batching of claims. And so if you wanted to appeal something through this independent dispute resolution process, they would only allow you would have to appeal each line item. So think my base rate would be one appeal and my mileage would be another appeal. And so that was very problematic to the air ambulance industry because you cannot batch claims appropriately, because technically when you transport a patient, both codes are you're always going to transport a patient for the most part with a base rate and a mileage code. And to actually have to bifurcate the two to appeal them was very problematic. And so there was a lot of lawsuits around batching. The federal judge has upheld some of that. And so CMS is still continuing to promulgate rules out of this. We did hear as of yesterday that their final rule that's going to address this batching process has been sent to the Office of the Federal Register for final approval to be issued. So we expect that to come down here hopefully later this afternoon to kind of release what the details around that is, which could as we kind of work through it, is there something that we need to consider as a ground ambulance industry? So those are some of the lessons learned through that process. You'll notice I'm not putting a lot of stuff in writing, so this is where you're going to want to take copious amounts of notes. There's a reason why I'm not doing that. And so we're going to talk through the Ground Ambulance and Patient Billing Advisory Committee. If you haven't already learned, we have been meeting since May. And so there's a lot of work that has been happening at the subcommittee level. So every committee meeting that is called has to go through a public hearing process unless they meet as a subcommittee according to the federal rules, which they call FACA committees. And so there's been a lot of work that's been going on. These committees have been meeting weekly, putting together, listening to public comments that have been issued, working with the constituent groups that they represent. and as well as working through some of the recommendations. And so if you haven't already, I'm strongly suggesting that you kind of put in the search. If you click on this, when you get the PDF, it'll take you directly to this site. But this is the CMS site around the Advisory Committee on Ground Ambulance and Patient Billing Advisory Committees. It does list out who all of the committee members are that were signed off on by the secretary and selected by the secretary. This is who they are. And the reason why you don't see a lot, there's certain things that I can do. I do chair the committee. So there are certain things that we cannot talk about that's still under deliberation or releasing certain documentation. Because we've had several public meetings already, and there's a lot of stuff that's already on the record, there's a lot that I can actually talk to you about as well. It is a broad jurisdiction that looks at from our own industry, from regulators, to also state and local officials, physicians, as well as the insurance industry, consumer and health advocacy groups, as well, are a part of the committee. So as of Tuesday, October the 31st and November the 1st, if you have not registered, this is probably, I would say, the most important meeting of the committee that will be public. And this is where they will be relaying the recommendations on what they recommend that Congress does and the secretaries do to fulfill the charge of the committee. And that is to prevent balanced billing, as well as provide some best practices around disclosures and consumer protections and things like that. And so if you haven't already signed up for that, I think it would be a really good idea. Probably one thing that you do want to listen to. The agenda has been posted as how the agenda will flow, and it will provide you kind of an insight into what the committee is referring to Congress, and will be a part of the public record. And then you'll probably hear about it in the media, because there's a lot of media that's registered to be listening in. So what is the charge of the committee? Remember, this is part one of two parts. This is recommendations only. Everything that's going to be recommended is going to have to be enacted by law. So Congress will have to do something. Your states may look at this information and say, we're going to update our state laws to look at some of the provisions that have been applied. They can look at this, insurance regulators, attorney general offices, depending upon what state you're in and who regulates and does what, they may take some information that they receive from these recommendations. But basically, the charge of the committee is to review the options around disclosures. So how are we disclosing charge? How are insurance companies doing charges and fees, as well as how are ground ambulance services doing this? How do you inform the consumer of their insurance options? So is the insurance carriers informing their consumers appropriately? Something around that has to be looked at. And then how do you protect consumers from balanced billing? What is balanced billing? And this is a key point to note. And if you attend the meeting next week, we're going to really talk a lot about that again, because there's a lot of this nomenclature definition is not understood even by our own industry. And so balanced billing, as it is currently defined within the No Surprises Act, is the difference between the billed charge and what the insurance allows. Okay, that is what a balanced bill. A balanced bill is not billing a patient for their copays and deductibles. All right. It is really only the difference between what is a bill charge and what is allowed. So if the insurance company does not cover a service, guess what? It is not a balanced bill. All right. They may get a bill for it because it's not covered, but it is not a balanced bill. Right. So those are things that we have to understand, and understand the nomenclature of what a balanced bill is. Definitions are really critical here, important to understand. A lot of us have been talking about it. So there might be some things that are opined on here. There may be some things that are not made as recommendations that might be a part of key findings, but understand the scope of what this committee does. The recommendations that the committee has to provide have to, at a minimum, address options and best practices around instances of balanced billing. Remember, this is the difference between the billed amount and the allowed amount that the insurance allows. It also has to talk about steps regarding consumer protections. Okay, so you're going to hear some things around some certain consumer protections that might need to be taken, as well as any legislative options that Congress can take to prevent balanced billing. All right. And that is to prevent out-of-network ground ambulance providers for billing the patients for the difference between the billed amount and the allowed amount, okay? And it is required 180 days after the date of the first meeting as well. So that's an interesting thing. The public meeting will be 183 days after the date of the first meeting. This is kind of what has happened in the timeline for you that are interested. May, August, November, you will see the final report that will be written. It should be released. We're thinking somewhere toward the end of January, could be into February or March that the final report is sent. So I'm going to stop there, and there'll be a lot more information they'll go, but I'll stop there and see if you guys have any questions around this process. Probably the one thing I get the most questions about right now. There's a lot going on, but I'll stop here and see if you have a question.
Any questions in the room around the balance billing? Yes, Tim.
Hey, Espo, this is Tim. Just wondering, as far as the recommendations go, I understand what you just said about specifically related to consumer protection, recommendations for actions that Congress can take. Can any of your recommendations from the committee include other things like funding mechanisms for mobile integrated health, funding treatment in place, and even addressing the local advertised rates? Because you're seeing a lot of states now starting to pass legislation that recognizes the local advertised rate as the amount, because that would solve or potentially answer that question of the difference between billed charges and what the insurance company allows.
So here's the one thing that I can say, because this has come up in the public hearings a lot, is I'm going to get at the last and then kind of work backwards from what you're talking about, back to the charge. So the reason why we were sent to an advisory committee was because of how locally regulated many of the areas were. So in the current provisions of the No Surprises Act, it does refer to if there is an all payers model or a state law or something on the books, that would take precedence around this initial, it's actually under the qualifying payment amount. We're going to probably redefine it a little different, but local and state regulations will be probably a key point about recommendations moving forward that needs to be looked at, whether it should look at the state, it should look at there's a local regulated rate within certain guardrails. And so it wouldn't be capricious and arbitrary. So you need to think if you've got certain guardrails that look at cost and different things like that, probably would be an appropriate guardrail. And if you don't have that addressed, then it's always going to have something related to whatever the feds do. The one thing that people are beginning to note is you need to be really careful where your stuff is in your insurance code at the state level. There are many places in insurance code that exempts out certain pieces. So think, in one state that just passed a state local balance billing law, they didn't realize that there were a lot of exemptions out of the code that they inserted to protect patients from ground ambulance billing, that exempted out state government employees, that exempted out university employees, that exempted out certain church plans out of the process. And so make sure wherever you're codifying your No Surprises Act language or your balance billing is that you're making sure you're amending all areas of the code to include everybody that's covered. Because if they refer to the state law and you have carved out certain members and it's not a part of the code, then the federal law will apply to those members who are carved out. So you theoretically might be thinking, well, in Colorado, we passed X, Y, and Z, but there's a certain portion of the population that may not be within that code, and it defers to the federal government. So those are things that I would be looking at as I'm working through what is happening at the state level. That'll answer, and if the state level says it's your local governing rate, and it has the parameters involved in there, then that could possibly be what your rate is, depending upon whatever Congress winds up with. And then if it's not covered, it's going to, of course, refer to the state. Now, regarding the stuff that is not currently covered, if you're talking about it under the jurisdictions of the law that this committee can opine under, which is not anything related to Social Security Act. So we cannot make recommendations on anything related to Medicare, Medicaid, VA, TRICARE, any type of policy. We can offer findings, though, findings that would say, we understand that sometimes the cost related might be because EMS is providing services for Medicare benefit and others that may not be covered. And we would strongly encourage Congress to work with the reg to understand XYZ. That can be done, but it won't be a recommendation. It won't be something that's voted on by members. But you can vote on coverage issues of things that might not be covered by Blue Crosses or insurance carriers that might be beneficial to that, and urge Congress to maybe mandate coverage on certain things. I will tell you, while they do some mandated coverages, the other side doesn't like mandated coverages when you're thinking from the issuer side of it. So remember, this is part 1 of part 2. But you could do there could be mandatory coverage recommendations. That answer your question, Ken?
It does. And one more question, if I may.
Sure.
Kind of an oversimplification, and I know that the dollar amounts vary widely, but we know essentially that Medicare and Medicaid pays a certain amount, 80% of the Medicare allowable rate, for example, first dollar coverage. Is there any possibility, if we truly want to take the consumer out of it, and if we're truly non-excludable and we differ from most other healthcare providers in that we go to them instead of them coming to us, we don't pick and choose our patients, we're open 24/7. I mean, there's so many different things. Can we include in the recommendations that maybe you can't answer this because you're on the committee, but why is first dollar coverage seems to be so off the table? What's the problem with that?
Overutilization is the biggest issue that you face, and not just EMS in first dollar coverage. So if somebody is not responsible for paying for any type of transport for something, it moves to overutilization. And they've seen that in the Medicaid programs. There's been a lot of studies that have happened in the Medicaid programs relative to that. When there is no responsibility or cost share amount. So that doesn't mean you can't remember, the No Surprises Act will refer to state law. I doubt you'll see anything around maximum out of pocket or first dollar coverage where there is zero responsibility for someone who calls 911. You move into these overutilization arguments, Office of the Actuary, things like that poll and look at the cost that would be there. And the Medicaid program, unfortunately, there's many Medicaid programs that have a lot of data that's been done by a lot of external groups that has data that shows when you do first dollar coverage issues like that, you increase certain things, there becomes an excessive utilization issue. Not saying it's wrong or right, I'm just saying that's an uphill battle for you, but that might be something that you might want to think about on a state level. If you can get that in some type of state balanced billing law or something like that, then it may defer to your state if you get that involved and you meet the parameters of whatever the feds pass in Congress. Remember, we're just recommendations. The Congress can do whatever they want to do. They can adopt the recommendations, throw them in the garbage, take a portion of them, make them a little different than what they want, because you still have the second portion of this, and this is basically Congress, and this is where advocacy starts. So just FYI.
Okay, thank you, Isabel. I just want to make certain that if you don't even put it in the recommendations as a consideration, then we know they won't choose it either way. It's kind of like the Publishers Clearinghouse giveaway. If you don't enter, you can't win. So,
well, stay tuned for next week.
thank you.
Okay. All right, let me get into, if there are no more questions there, I'm going to get into the Veterans Administration. Well, I can't see you. Oops.
I'm sorry, there's one more question on the previous topic. Hang on.
Sure.
Later.
what, or is there a benefit to contracting with the insurers rather than being out of network?
Ooh, that's a loaded question. Here's what I'm going to say about contracting with insurers in network or out of network. If you can move into a good faith negotiation with a payer or an insurer, it might inure to your benefit because you're taking the consumer out of the middle. And if you can get to some adequate compensation, you can look at your contractual language and it removes some administrative burden. It provides you with some other intangibles that it doesn't matter whether the community around you likes that you enter into them. There are some positives of doing that as well. And so, because then it removes all this back and forth with this surprise billing, because this really only impacts people that are out of network. And so there are many that are going in network. You're seeing a lot of that now on the air ambulance side. It was hard at first, but now you're beginning to see many more individuals going into network. So ground ambulance, you are seeing that everywhere. If you do a lot of interfacility transfers, if you do a lot of transports that are non-emergency in general, it probably is a wise idea to be seeking to do good faith negotiations with the insurance carriers. If you're on the 911 side or on the emergency side right now, I think it's going to come down to, does it make sense? What is your process of being able to go into procure a contract with an insurance company? Some it's just really hard to do because they got to go through 3 readings of the city council, or the city attorneys don't want to do something. And so sometimes it has nothing to do with whether they wanted to go into contract or not. It's the process of the local government to do. So I think wherever you are, if you can move into a good faith negotiation and agree to something that's like, hey, that might work for you. There are many emergency providers across the nation that have successfully negotiated adequate contract, very reasonable contracts with insurance carriers.
Thank you.
Thank you, Hasbel. Any other questions on the balanced billing topic? All right, thanks, Hasbel. Go ahead.
You bet. So let's talk about the Veterans Administration. Some of you may know what I'm talking about, some may not. So I'm going to give you a really quick and dirty because this is an issue that has really percolated. If you're not aware of it, I'm going to strongly suggest you go do a deep dive into your data to understand what the impact will be of a rule that has been proposed. And so back in 2023, on February the 16th of 2023, the VA published a final rule on changing of rates from the VA for special modes of transport. Many of you might be in here thinking, well, yeah, I do VA transport, but I don't do billing, so you may not know what I'm talking about. This might be something you want to go back to your billing department on, or you want to go back to your billing agency to really try to understand this process. Now, what I'm not going to try to do is have you break it down into the different levels that they serve. I'm going to give you a high-level overview over it, but you just need to understand right now is what could be the impact of this rule. We're also finding out the VA has not been paying claims appropriately from the VA. Whether wrong or right, but there has been several different ways of payment authority that have actually been codified that they should be paying that they have not been. But this rule was basically to affect one small portion of the VA business. So if you're contracted with the VA, we're not talking about that. We're basically talking about those patients that call 911 who are veterans. They are going to go under some type of payment authority when you transport them to either a VA or you transport them to a non-VA through a 911 response. You could even sometimes do an interfacility transfer from an emergency department to another hospital for care or to a VA that may fall outside of a contract with the VA. And so it moves into different modalities. When they put this original proposed rule out prior to 2023, they asked for comments where they were paying for a certain mode of transport at bill charges, or they were paying it at cost. And the VA was determining at cost to them was your bill charges. So it's what we called beneficiary travel at the time. And they were paying some of your what we call Benny travel type claims where you were not contracted at the cost of your service. So if you billed $1,000, they paid $1,000, but it was a small portion that they were doing. And this is the rule if you want to read it. Well, some people started to go back and analyze their data, and they looked and they went, wait a minute, I'm doing a lot here. I'm doing millions and millions of dollars in this type of transport, or for some smaller agencies, it might have been a few $100,000 a year. And so now they're going to take all that away. And so there started to be this roar that started to happen within the industry. What they didn't realize, and what many in the industry who hadn't done their research yet hadn't realized, was that this all was stemmed off a report from the Office of the Inspector General from the Department of Veteran Affairs. It was a whistleblower lawsuit, a whistleblower from the VA that had reported this out, and the Office of Inspector General came in and looked. And if you want to look at this report, it is here. There is a site when you get this PDF that you can click on this link, and it takes you to the OIG report. It probably is a really good read. If you're someone that likes to know and just doesn't say, well, I heard Asbel say this, but I want to read it for myself. This is great documentation. Within there, a whistleblower says that they observed contract officers inadvertently paying for veterans under the wrong payment authorities and giving them bill charges. Now, do we think that the contracting officer that was paying under these different authorities were doing it wrong? No, what I really believe was probably happening is that they wanted to take the veteran from getting a patient responsibility, because under the payment authorities, the veteran does get billed for some copays, but under some authorities, they do not. It just depends on where they qualify. And so I don't think it was done intentionally, but it was noted by the whistleblower that the VA was spending a lot of money in areas where they shouldn't probably be paying it this way, and they should be paying everybody at the Medicare level. So the one thing that you should be looking at is understanding the way the payment authorities work. So there are technically 4 payment authorities, and I'm just going to include one of the payment authorities into another. I didn't break it out here to not convolute it, but technically what they're looking at is beneficiary travel. And this is basically where they're paying that actual cost. A lot of times it's that resident that is going directly to the VA, or they're going from the VA to another VA, or the hospital to another VA, and there's not a contract. That typically falls under, that's simplifying it, that typically falls under beneficiary travel. And technically, if they qualified under that, the VA is required to pay the actual cost of the ambulance transport, or technically, or whatever the secretary deems, okay? And so the secretary could actually promulgate a rule to define what actual cost is and what that reimbursement methodology is. And that was that rule that you saw where they said, we're moving actual cost and we're moving it to Medicare, and the secretary has the authority to do that. Under what most people think is community care. You remember this debacle happened several years ago where veterans weren't being paid to go. If they called 911 and you took them to the local hospital that was not a VA, that oftentimes that transport wouldn't be paid if there was a VA in the area, until community care came along, or what we call community choice. Now, community choice did indicate that you either pay the lesser of the ambulance providers or the supplier's bill charges, or the amount determined under the Medicare ambulance fee schedule. And when community choice was passed, the secretary did pass a rule or a regulation that made it into that became a final rule that established the payment at the Medicare ambulance fee schedule. So technically, community choice members should be paid under the Medicare ambulance fee schedule. Or you could be under what a lot of us do with 911, is it falls into the Millennium Act. And the Millennium Act has a few components of that, like a service-connected, and the service-connected side, which should be a small portion of that, would be like they had a service injury, or it was PTSD, and there was something that triggered their PTSD. They called 911. Technically, it could be service-connected. And because they hadn't addressed what that payment should look like, a lot of times it was referring back to beanie travel at actual cost. But actually, the 1725 is where most of your stuff probably went. And if you noticed, you had to coordinate the benefits with another payer, meaning if the veteran had Medicare and no supplement, you would have to bill Medicare first, and the supplemental payment would be the responsibility of the veteran. Because technically, the Millennium Bill indicates they can't pay for it. That was challenged, and they came back and allowed for some of it. And so about a few years ago, you started to see a lot of people who were billing the veterans Medicare or Blue Cross or some other payer. They would balance bill the copay to the VA, and the VA came back and paid 100% of everything. because they're applying either incorrect payment authorities, think of the whistleblower lawsuit, to make sure that the veteran didn't have to pay anything, because they felt like they either had to deny the deductible because there were some exclusions in that recommendation, which would still hold the veteran responsible for payment. And so what that means is, and what you need to be thinking about, and this is the proposal, it's only changing one of the things. Technically, the VA can go back and say you should be paying under the right authorities. Okay, you've been paying in the incorrect authorities. So when you get a payment from the VA underneath their remits, it tells you which authority should be paying for which VA. So if you run your analysis and you look at your stuff and say, I'm going to go look and see, I don't have a contract with the VA, but how many have I been being paid at billed charges? This proposed rule basically says, effective February the 16th of next year, unless something changes, there's a lot of lobbying happening on the Hill and advocacy work happening on the Hill, your payments that you've been getting paid billed charges on are almost in their entirety going to go to the Medicare. So for instance, if I've been making $200,000 from the VA on these transports, then you need to think all of that, the delta between the Medicare that they would pay for and your bill charge is what you will no longer start receiving after February 16th, unless they do something. So ultimately, there's a lot of things here that could happen. Technically, there's a law that has been passed, and I'm giving it to you here, or not a law, but a law that's been introduced by the senators, John Tester and Jerry Moran. They're both chairman and ranking member of the Senate VA committee. That is basically indicated and requiring the Department of VA to not modify or change their reimbursement rates until they do a study. Basically rescinding or stopping the implementation of this rule. Now, it remains to be seen, and it would have to be challenged, if they're paying under the wrong authority, if this would apply, because it's a change in reimbursement rate. Because technically, if they're not paying under the right authority, they should have been paying under the right authority. This technically wouldn't apply, so it'll be interesting to see if it's challenged and how that is implemented. If this passes Congress. Currently in the dysfunction that's going on now, it'll be interesting. But we do have until February the 16th to make sure that this would be passed to see if it's modified or not. The story that I'm trying to make sure that you understand here is, if you are not, now you can send and scan this QR code and send your senators there in Colorado and ask them to support this bill. But I would at first, if you don't know what I'm talking about, I would go and run your numbers and see what the impact of this rule is going to do to you. Because some people, when they start running their numbers, didn't realize this is a huge impact. And then some have run their numbers saying, this ain't impacted me at all. I don't care. And then some have even said, well, they shouldn't have been paying it anyway. And like I like to used to say, it's just lagniappe money that we've been getting for the last few years, and they've now figured it out. So depending upon where you are on that will depend upon how supportive you want to be of what's going on here. But just FYI, this is going to happen on February the 16th next year, which will impact some providers that may be getting payment from the VA at bill charges. All right. So what to expect? Go ahead. I'll stop. Yeah.
Hey, I've got a question from Terry in Durango. Does this mean the VA will actually start paying all claims in a timely manner?
Well, unfortunately, the rule does not address that. It just addresses more of your reimbursement. They technically should be paying within 30 days. I would strongly suggest that you make sure you're submitting your claims to the ECAM system so that they are noted and not doing them via paper, which a lot of them want to do. So that would probably be the first thing that I would suggest, because you have a lot more traction of ensuring that they pay timely if you go through that system. But it does not address that, no.
Thank you.
All right. The next 18 months, what to kind of look for, and I'll talk about data collection there. We both know they've wound down the ET3 model, which was the Medicare model of your TIP or MIH or whatever we wanted to call it. It is no longer there. For some people, they're not surprised. Like me, it's pure economics of the reasons why, regardless of the way that it was implemented or not. But this is a step back for the Medicare side of the program. If you're doing MIH CP, you should be getting reimbursed. There's a lot of different rate of getting reimbursed through different methodologies, setting your system up a little different from an ambulance perspective. I'm not going to go into that too much because there's a lot of us that are out there that have varying opinions on the reimbursement side of it. Mine's a lot more practical, but there is ways to get paid. You shouldn't just shut your program down. If you work hard, there's innovative ways to get paid for your programs. That have nothing to do with Medicare. But from the whole Medicare payment policy perspective, this is a setback for many of us that have been working on Medicare payment reform. It remains to be seen what's going to happen with the Medicare Advantage programs. So far, we have seen those that have these programs, there is no sense to want to get rid of these programs, which is good. And so we'll just continue to watch and see that. There's a lot of programmatic dollars out there through grants and foundations and setting up under different supplier types or provider types that are getting you paid. So just a lot of great innovation happening around these reimbursement models. The next thing that you should note is Senate Bill 1673. So this is Cortez Masto and Collins that are leading a joint effort to increase our reimbursement because our extenders expire at the end of next year. This is really important to note because we are getting into, we probably have another 10 months or so to do something about this. And the reason why I'm saying 10 months or so, even though it's about 14 months until we expire, we have a major presidential election next year. And there's going to be a lot of noise, a lot of distraction. There's already a lot of distraction. And remember that 2 and 3 and 22.6% that you've been getting for Medicare and Medicare Advantage programs will go away unless it's extended. There is a request to extend that and take the urban transport to increase it to 3.4% from 2%, and 3% for rural to 4.3%, and then for super rural from 22.6% to 26.7%. And so this has bipartisan support. However, it's not really moving at a lot yet, but there's a lot more advocacy happening around this. So strongly suggesting we understand this nuance. This is probably the next thing that we're looking for. The reason why we're asking for a 2-year extension is because the data collection that y'all have been doing, and we'll talk about here, and I know Scott Moore's talking about as well, is that that is supposed to feed into a report back to Congress sometime in 2025. But it's basically required 2 years from the date of the release of the first results of the data collection period. And I'll talk a little bit about that. So if they release in first quarter of next year, then that means first quarter of 2026, they will release what should happen to the Medicare program as it deals with these extenders only. They are not required, and they will probably not opine on additional funding around things that we've been advocating for, like treatment in place or treatment no transport or community paramedicine or MIH. They technically, their scope and their regulatory authority, as they have been given, their statutory requirement is to provide Congress with what they should do with the current ambulance fee schedule program versus continuing with these extenders. And so that's kind of what we're paying very close attention to. So just remember that that's what their statutory charge is. But this is probably something to really get around and understand. And we really have some really good support on this. Really is going to come down to dollars and cents, folks, and what your last package is to kind of move this forward.
Quick question on the last topic before you move on, Tim.
Yep.
Asbel, is it for treatment in place, and you mentioned that there are some commercial plans still paying it and Medicare Advantage. Is there a modifier we should add, make certain so that they understand that it is a treatment in place claim?
So I will tell you, I have a whole other presentation on treatment in place. And so treatment in place as it is, I'm using treatment in place as it is currently defined by the ET3 model. So that would mean you would have to have a connected telehealth vendor through a qualified healthcare practitioner. And so many states passed a TIP model very similar. Some actually did not pass it as such. I have not heard of a state that has yet discontinued that actually passed the TIP component. So in some states, you can still do TIP if you have that qualified healthcare practitioner. In some states, they call it TIP, but they disconnected the qualified healthcare practitioner, and it moves into more like a treatment, no transport type model, model where an ambulance response still happens, but you don't have to technically have that qualified healthcare practitioner.
Okay, and then a follow-up on the protected patient access to ground ambulance, 3.4, 4.3, 26, or 26.7%. Is it still in the bill requiring CMS to reevaluate the zip codes because of the inequities?
Yes.
In
Yes.
urban rural?
That's still in there, yes. To do a relook at the zip codes and that piece, yeah, that is still there, yes.
Perfect, thank you.
Because that is a problem for several hundred zip codes.
Yes, 100? Several hundred?
Yeah, there are several hundred that's a problem with. Or at least the analysis shows. If you think it's more than that, you probably need to produce some data on that. Okay. Let's go to cost data collection next, because I know that's where a lot of people are. They've got the first 2 years. I will tell you the RAND Corporation is the contracting entity that has been hired by CMS to evaluate the current data that we're beginning to see. Here's the issue, folks. There's a lot of concern about the rural data that has been submitted and what has been reported on. That is very concerning. There is an obvious concerted effort by RAND to look and understand what's happening in the larger agencies, because there are so many issues relative to what was submitted by the rural and super rural agencies. And so we're beginning to see a lot of reach out. Some of you may have been reached out asking for some clarifications on what you've submitted as well. And so we are anticipating that they are finishing up and beginning to look at the data and finalize data. We also understand, and we've asked for nuances around some providers that didn't have someone to certify the results because they were so small. There's only one of them. And so that component of validation has not happened. The good thing is there is a lot of reach out happening. There's a lot of grace that's been given in this period to providers as well. Practically speaking, I would tell the industry, and remember we look at this by geographical, this is looked at by operational and geographical differences, because that was a mandate that they had to look at with the data in the statute. Is practically speaking, if you are not used to doing cost reports at all, mainly through Medicaid financing and certified public expenditure processes, it is probably going to be problematic for certain organizational types, is what the concern is. And so what is the impact of that going to be on communities in very rural areas? What does that look like? Is there going to be an enhanced reimbursement model on that? CMS can actually do that, but there's a lot of work that's being done by others from the Office of Rural Health and others to look at reimbursement in a different mechanism for very rural areas or areas that have ambulance deserts or a very low patient census, think 0.2, 0.3, are less or not. And this is something that many of us have been saying, many that you are in this room and others have been talking about, more like cost plus formatting, different things like that, maybe integration with other types of systems. So I'm anticipating this is going to reveal a big issue. And we've anticipated and tried to prepare the industry that the data may not produce what you think it's going to produce, looking through your own lens. And oftentimes we view EMS through our own lens versus a holistic lens of what it could be viewed from a 50,000 foot view versus a 5,000 foot view. And so the good thing is the data should be looked at down to the state level. And so understanding what that looks at. Remember, the current system does have a system that looks at different geographic indices. And so it'll be interesting to see what RAND comes out with, and then what MedPAC does with that when they evaluate that moving forward. But we still have several years out to address that. So even if the data comes out in January, February of next year, and it is something that the industry doesn't like, remember, it is first pass data. First pass data is never good data. That's historical. And many of us that have been here, I think I've spoken to many of you before, and I used to give that home health reference, that it's been now more than 20 years ago when home health did their first reporting piece of it. This is where they lost so much of some of their money that they had received, was because of inaccurate reporting and not understanding what they were doing when they were sending it through, and why we've done such a concerted effort to try to educate the industry on this. So I'm keeping my fingers crossed that the data is going to be better than what I anticipate the data to be, but I could see an analysis being done of using the 80-20 principle. So using the majority of the data submitted that encompasses most of the encounter data, but doesn't understand the dynamic of the different organizational types. And so theoretically, think of looking at LA, Fidney, and then the large for-profits and others like that, aggregating all their data together and coming up with some numbers by looking at the 80-20 principle as well. Not saying that that's what they're going to do, but just saying that there seems to be a lot of issues with the data that they're beginning to see, that try to look, or what we would think would be issues. They may not think it's an issue, but we think it's going to be problematic. That makes sense?
So Asbel, is it, when you refer to issues with the data, is it because agencies aren't submitting the data? Or
no, they've submitted it. Some of it would be that it's incorrect. So in some areas, it might be they didn't report anything for salaries because then they didn't report, they were volunteer and they didn't report anything in the volunteer section. There's things related to, did they categorize people incorrectly in the personnel side of it? Because remember, not all cost data is permissible data. And we don't understand that as an industry because we've never really reported data. But there are some costs that are not permissible costs. They're impermissible costs. Think direct patient care, that's permissible. But if it's not indirect pay, or it's related to something else or whatever like that, it could be discounted. And then it looks at your overall utilization of how you treat Medicare, Medicaid. It determines costs by each of the different payer categories because of cost shifting, things like that. Depending upon how you report it, could be dependent upon what comes out in the data. So, and we didn't see what everybody reported. And then there's a lot of other people out there teaching other people related to not understanding what it is. Oh, this is easy. It's like what you do for G&T projects. And now we're seeing a huge audit happening around G&T that is concerning to a lot of us as well, or the Office of Inspector General is going into a lot of states and reviewing G&T programs because of impermissible costs. So that we have that piece as well. So we're expecting, this is not surprising that the first run of the data might have some flaws in it. It's the whole issue that one of the associations, the American Ambulance Association, partnered with another firm in Oregon to produce the AMBER data. So we did have a lot of people that I know were putting in there. Scott will talk a bit more about that in the AMBER data as they continue to slice through that data to see where there might be some problematic areas, because some of this might take advocacy. So one thing about data. We'll see. Just preparation, level set. Let's hope. But there's a lot of questions that are being asked by a lot of providers right now. And so that is making us, the questions that are being asked are making us begin to think something. And so that's what's interesting.
Thank you, Asbel.
All right. I think we're about, I'm probably over time, aren't I? I think we're about done there. So I'll just kind of
Are there any questions? Any questions for Asbel online? All right, thank you, sir. Every time I hear you, my head just about wants to explode, and I don't know how you, keep all of that moving forward. Oh, wow, just so much going on.
Absolutely. And Kim, I'll have Susanna send you this presentation so people can have it and you can send it out to everybody. Nice seeing everyone.
Thank you, Bill.
Bye, y'all.